So thank you all for joining us. This is a discussion of clinical case scenarios. And so me and my colleagues here are going to address questions as they come in. There are two vehicles that you can use to submit questions. One is you can go up to the microphones, which there's one on either side of the room, or you can submit by using the QR code, and it will pop up on our screen, and we will filter those appropriately. So I'd like to just quickly go and introduce the folks that have been eager and willing to help participate in your impromptu questions. You know, I think this is a great way to discuss issues of clinical controversy or just input. So my name is Debra Patt. I'm a breast medical oncologist at Texas Oncology. I practice in Austin, Texas.
Tari King, breast surgeon at Brigham and Women's Hospital and Dana-Farber Cancer Center.
I'm Vincent Salomon. I'm pathologist practicing at the Institut Curie in Paris, France.
I am Kelly Shanahan. I am the patient advocate. I've been not dead yet with metastatic breast cancer for 11 years and used to be an OBGYN.
Hi, Erika Hamilton, medical oncologist. I lead the breast cancer program at Sarah Cannon Research Institute in Nashville, Tennessee.
I'm Ingram Meattini, radiation oncologist at the University of Florence, Italy.
Sonya Reid, breast medical oncologist at Vanderbilt in Nashville, Tennessee.
Hal Burstein, a medical oncologist at Dana-Farber Cancer Institute.
Wonderful, thank you. Okay, we're going to get started. This is a clinical question about adjuvant chemotherapy. So this was submitted from an anonymous person virtually. There's a 74-year-old patient that presented with a new breast cancer, clinical T1C N0M0 triple positive invasive ductal carcinoma, underwent primary surgery with partial mastectomy, and was found to have an additional 11 millimeter triple positive invasive ductal carcinoma, but also a 6 millimeter triple negative invasive ductal carcinoma with a Ki-67 of 80%. And I assume no lymph nodes that were involved. And their question is, in addition to appropriate local therapy, do you all have suggestions regarding the best adjuvant chemotherapy?
I have a comment to make. The positivity of the triple positive, is it with ER between 1 to 10% of positive cells?
They did not specify, and I don't have a way to interact with them, but I will say for argument's sake that it's more than 10%.
Okay.
Oh, yes, okay.
I think the first thing is you ask the patient, is this a 74-year-old who lives in my town and is still skiing double black diamonds? It is a 74-year-old who can't get out of bed. What does the patient want to do?
A good performance status, ECOG is 0.
Yeah, maybe I'll chime in with a suggestion. You know, we have pretty good data that HER2 positive tumors that are over the size of 5 millimeter actually have, you know, quite a high recurrence rate, around 20%. If we don't do anything, I think this is a patient that, particularly, you know, being healthy but being older, that I would feel comfortable with weekly Taxol Herceptin. It has excellent cure rates. In terms of the triple negative, you know, it's quite a bit smaller, 6 millimeters. But I think we do have the advantage that the patient's going to be getting weekly Taxol anyway, and I think this would probably be adequate for a very small triple negative tumor.
Any other feedback? Okay. Anyone at the microphones? Not yet. Okay. We have a second question. Do all high-grade neuroendocrine primary breast cancers require adjuvant chemotherapy, or should we be considering Oncotype to be performed on some of these cancers? Maybe if so, what guidelines would we use in an ER/PR positive, HER2 negative neuroendocrine breast cancer with a Ki-67 of 45%? And it's saying about 4 centimeters in size.
Well, the first thing to do is to ask the pathologist to talk about neuroendocrine carcinomas of the breast.
That's a great idea.
Oh, thank you. So the fifth classification, WHO classification, made a big deal to isolate and identify neuroendocrine tumors. But it came out that in practice, in fact, all epithelial neuroendocrine tumors are to be considered as invasive carcinoma within the breast. So the authors of the chapter of the 5th classification made a step back, saying that it's rather more practical and clinical meaningful to consider them as invasive ductal carcinoma with neuroendocrine differentiation. So just to make that clearer. And I think that in the 6th WHO classification, it will appear much clearer.
And so if you have a T2 in 0 cancer with a Ki-67 of 45%, then would you all think oncotype is a reasonable way to understand if there's a role for adjuvant chemotherapy to reduce risk in that patient population?
I think it's unclear, right? When we look at the studies that approved oncotype, we know that not a lot of these patients were included. That being said, I would treat it as if it was no special type and do an oncotype to guide further treatment as we would other in types of invasive ductal carcinomas.
Great. Okay, the questions are coming in now.
There's some at the microphone.
Oh, they are. Who's at the microphone? We'll go to the microphone. Please, go ahead.
Hello, thank you. This is a maintenance HER2 duration question. 13 years ago, 58-year-old had metastatic, hormone-negative, HER2-positive breast cancer. She was treated with the taxane and Herceptin, went into a CR, and has been on maintenance Herceptin since that time. What would you do, and would you use solid MRD in this setting without data?
How many years has she been on single-agent Herceptin?
About 12.
12 years. And where were her sites of metastatic disease?
Liver.
I don't know. What about talking to her about enrolling in Stop Her too?
Well, it's a matter of availability. In the absence of that, what would you do?
In the absence of Stop HER2, I would continue therapy because this is still a data-free zone, but I would definitely encourage enrollment in that clinical trial, given I think that will definitely help us answer this question in coming years.
Would solid tumor MRD have a role?
I think the bigger issues we don't know. It may, but I think at this point we really don't know. So I think I would feel uncomfortable using that to guide what we decide outside of the context of a clinical trial.
I will say, I think the bigger point about your question is how to manage this uncertainty in this environment, and it's really tough. I think depending upon how toxic the therapy potentially is, and you know, thinking about sort of the risk versus benefit. As I think about that, I have had patients that have chosen to stop therapy after more than 5 years without evidence of disease in this scenario that have recurred in the liver and with brain metastasis. So given my limited experience, I would be reluctant to support someone discontinuing therapy, but that's a very anecdotal answer where I think there's very limited data, and I hope that studies like this can inform those choices better in the future.
Yeah, I agree. I think it really kind of comes down to the risk of continuing therapy versus the benefit, right? Especially with liver disease, you know, is this patient cured? Maybe. What we do know about trastuzumab is, you know, the biggest side effect really can be ejection fraction decline. And if people don't get that in the first several years, they're unlikely to get it afterward. So I guess it also comes down to how inconvenienced she feels by having to get the trastuzumab. But I agree, my bias is that I would want her to continue.
I'll take a little contrarian take here. I'd be pretty comfortable stopping Herceptin at this point. In the lobby just a little while ago, a patient question was posed to me about a younger woman who'd been on it for 12 years in exactly the same situation and wanted to have a child. I'd be very comfortable stopping trastuzumab to let her have a child. We're never going to know the answer. Even in the Stop Her trial, they stop after 5 years, I believe, and this person is another 7 years beyond that. And you know, Kelly can speak to the day-to-day issues of being a cancer patient with advanced disease, but if they wanted a holiday, I'd be very comfortable.
And Hal, to that question, since we're dancing in a data-free zone, would you restart her Herceptin after she had successfully born children?
Depends how many she wants to have. I think, if she wants 2 or 3, she'll need to keep off of it for a while. So, but I think you've probably cured your patient. I mean, in all realistic likelihood.
Okay, good. Okay, another clinical. I'll take another from the microphone. Go ahead.
Hi, my name is Sarah Caccini, and I'm a medical oncologist with a breast focus in rural Virginia. I have a 46-year-old premenopausal female with invasive lobular carcinoma, grade 2. She was ER/PR greater than 90%, HER2 3+, Ki67 was 43%. She was a CT3CN1. She had 6 cycles of neoadjuvant TCHP, had surgery. She had 6 centimeters of persistent disease, an RCB of 3, 6 out of 7 lymph nodes positive. She ended up being a YP, T3, YP, N3A. And I ran a HER2 KISH on her. She just transferred care to me a few weeks ago. Her surgery was back in August. She's been on Kadcyla since then. And the HER2 KISH was negative. And I know that in the Catherine trial, they had some positive to negatives. But just given this patient had such a poor response to neoadjuvant therapy, I was curious if there would be any role in potentially giving her AC or potentially finishing out the Kadcyla and then doing a CDK4/6 inhibitor. I just kind of wanted to get some thoughts. She's just very young and has a large burden of disease that was found at surgery.
Let me ask a clarifying question. I think it's a difficult situation that's common that we see when patients fail to have a great response to neoadjuvant therapy and then their disease seems to change character whenever at the time of surgery. So prior to surgery, she was ER/PR positive, HER2 3+, and post-surgery she was?
Post-surgery, I just got a HER2 IHC, it was 0, so then I had them run a KISH, which was negative, and I don't have any other markers yet from
So
that.
you didn't repeat ER/PR?
I sent it for external path review. She just transferred care
Okay.
3 weeks ago.
Please go ahead. You said it was a lobular?
Yes.
So first of all, on a biopsy, if you see a lobular being HER2 3+, it has to be double-checked because it's very rare to have amplification for a lobular breast cancer. So
They're retesting the original biopsy with a KISH. I'm just waiting on it.
okay, and so the hypothesis could be an heterogeneous tumor being negative after or after treatment. I don't know what your views about that, but heterogeneity may explain that, but it's,
So definitely, for the audience, anytime you have a triple negative lobular or a HER2 positive lobular, you always want to double check that because they are very uncommon. The majority of the data that's out there, though, does support that if they're treated the same as their ductal counterparts, that they should have similar response rates. So unfortunately, it doesn't sound like this patient did have a very nice response. Hopefully, she's still strongly ER and PR positive because we're learning more about the biology of lobular cancers, and they have a unique ER syndrome, and so they respond differently to ER therapies. So definitely, as a premenopausal woman, she would need ovarian function suppression if she's still
I just
menstruating.
started her on it. Unfortunately, it hadn't been started yet. So.
Yeah, so that, plus an AI,
Yep.
and then, the role for CDK4/6, I'll let the oncologist speak to it, but certainly, there's debate whether lobular cancers truly respond to chemotherapy anyways, and so we think, certainly the backbone will be that endocrine therapy, and hopefully she'll have some durable response to that.
So just a question then to follow up. So if her original biopsy specimen, the KISH, ends up coming back positive, and then now it's negative, and she's still ER/PR positive, do you guys think I should switch her therapy from the Kadcyla or just continue the Kadcyla and maybe follow with neratinib? I'm just very conflicted about what to do.
Yeah, I would continue TDM1 at this point, but I would definitely advocate for neratinib after the year, I mean, with the caveats of the data, but I think endocrine therapy as well as ovarian suppression, clearly I know would also be indicated, but I would, in this patient, I would definitely advocate for neratinib after completing T-DM1.
Even though she switched.
Correct.
Good case. I think the switching cases are tough. And then in general for residual disease, some nice clinical trials open too to look at reducing risk further. Okay, this came up yesterday.
We have an extra.
I'm sorry.
Sorry, no. If I had something about local therapy, of course, this is really interesting case, and you should thank you for this because lobular is really a distant entity, so this is really important. In this case, the patient should receive postoperative radiation therapy, regardless of TDM1 or whatever, because you can give concomitant. So we have data now, so it's safe, and she should receive a postoperative radiotherapy.
It's done.
Thank you so much.
Perfect. I'm going to talk about this one. This came up yesterday in the new FDA approvals discussion. I think we're so lucky to live in a time of tremendous therapeutic innovation, but sometimes we have multiple pieces of data that we don't know how to harmonize with other clinical trials. So in the event that we have a new patient with metastatic breast cancer with bone-only disease, which is common, ER positive, with a PIK mutation, with a PIK3CA mutation, and an ESR1 mutation, first-line therapy, what would you choose?
Is there de novo metastatic disease?
De novo metastatic bone-only disease.
You really shouldn't have a de novo case with an ESR1 positive mutation. And that would be very unusual because those are usually enriched by selection from treatment with an aromatase inhibitor. So the provocative question is whether you should go right away to a triplet combination of endocrine therapy plus, in the study, palbociclib plus inavolisib, which look good. I'm not sure you have to do that. I would probably start with an AI and a CDK4/6 inhibitor, and then if at time of progression she's an appropriate candidate, then I would switch to a PI3 kinase inhibitor. But I agree that you don't have a data to tell you which way to go on that.
Yeah, so I brought up this question yesterday in the session too, because in that trial, of course, a high percentage of those patients had visceral disease. And so these patients that we commonly see with bone-only disease, will they benefit more from having sequentially targeted therapy? And it's a question that we don't have an answer to yet. Any other thoughts on that?
Yeah, I mean, I think I probably would not apply the inavolisib data here because in that trial it was really people that relapsed while on adjuvant AI or in close proximity. We do know from the meta-analysis of the CDK4/6 trials that having a PI3 in itself doesn't necessarily predict a poor outcome with a CDK4/6 inhibitor. What really appears unique in the inavolisib trial is that extra addition of people that were quickly relapsing. So I agree with how I would be thinking about CDK without PI3 targeting in the first line setting.
Perfect. We have a question over to the left.
Hi, I'm Ashwini Bhatt from Baylor Scott & White here in Central Texas. I have two questions about Oncotype use. I know Oncotype DX is usually used as an adjuvant tool after your surgery to predict whether a postmenopausal node-positive woman needs chemotherapy. But say the surgeon sends you patients who fall in the responder criteria, but they have a big tumor, or they are asking you to consider neoadjuvant chemotherapy, but you are not so sure. So in those patients, can you send Oncotype pre-op to determine whether they will benefit from chemotherapy? And my follow-up question to that is, if you did send it and it came back low, and the patient went for surgery and gets upstaged with more than 4 lymph nodes, then would you disregard that Oncotype and give chemo?
Okay, can you restate that a little bit? So you're referred a patient from surgery and you're considering whether or not they might benefit from neoadjuvant therapy because surgically they're not a good surgical candidate first?
Not exactly, but the surgeon wants to, say, do less invasive axillary staging. Like they are node positive, but they want to do targeted axillary node dissection instead of a full axillary node dissection. Otherwise,
Okay.
she's otherwise falls in the RX pointer criteria. So
Okay,
they're
I
sending to
understand.
you to consider neoadjuvant, but I'm not sure the chemo would be beneficial.
Got it.
So I'll jump in first. So you absolutely can do an oncotype score on the core biopsy. It has been validated to be consistent with the scores from surgical specimens. And if that information would help determine whether a patient is a candidate for chemotherapy or not, then we often will ask that question up front if we're considering trying to downstage somebody. I certainly would not want someone to get chemotherapy solely for the purpose of trying to downstage, but if they were a candidate for chemotherapy regardless, then it's a nice conversation to be able to have to say, well, this is the possible secondary benefit that you would get from the chemotherapy if we used it before surgery. Now, certainly with hormone receptor positive HER2 negative disease, we don't expect a lot of PCRs, and the PCR rate in the axilla is still going to be low, maybe in the teens. So she still needs to be prepared for the possibility that she still could require a lymph node dissection, even if she has a nice response and achieves a lumpectomy, she may still not avoid a lymph node dissection.
So I'll just add to that I think setting expectations with your surgeon around the likelihood of having a pathologic complete response in that case is low, as you mentioned. But I know there's sometimes a lot of other reasons in terms of timing and planning that if you're going to require chemotherapy at all, it may be beneficial to have it before surgery that makes that a more convenient strategy.
Yeah, I would just to add the European perspectives in this case. We don't use Oncotype for the preoperative. We can't, and probably this is a personal opinion. We have no data to support a decision based on the genomic test. So please go for a neoadjuvant if you really want to reduce the burden on disease. But you have to take into account the biology still that is the main driven in this case.
What about the second part of the question? Like if you did send Oncotype pre-op and then the patient, it came out low and you did not give chemo and the patient went for surgery, but when they underwent surgery, they had more than 4 lymph nodes, which is outside, it's not validated. Oncotype was not done in patients with N2 or higher disease. So would you say, I'm going to disregard the Oncotype and give chemo now?
Is Harry Baer in the audience, by the way, by any weird chance? So Dr. Baer ran a trial where they did the preoperative biopsy, saw the oncotype, and then patients were randomized to endocrine therapy or chemotherapy as a function of their oncotype score. And as you would predict, there's very little benefit clinically to preoperative chemo if the oncotype score is really low. So that's some helpful data. If they end up with 14 positive lymph nodes, you're going to be obliged to give them chemotherapy. And this was how old a patient, roughly?
This was around like 60s, late 60s.
Postmenopausal. I mean, I don't think there's going to be a huge difference in a postmenopausal woman if there are 3 lymph nodes versus 4 lymph nodes. At some point, your risk keeps going up and you have to make a clinical judgment call on whether it's worth it to consider chemo just because that is the historic standard of care.
Thank you.
And then maybe we'll go to the microphone over here.
Yeah, so I want to just build up on one case which was, I have a patient, 62-year-old postmenopausal. So she was on 2.5 years of letrozole in the adjuvant setting. She had node positive cancer, so she got her standard of care adjuvant chemotherapy, radiation therapy in 2.5 years. And then she relapsed, bone-only disease. That's why I'm making like on the previous case that was asked. And wall-to-wall kind of involvement because she presented with pancytopenia. And her every bone was riddled with, and virtually no visceral metastatic disease, but every bone was, and bone marrow was positive, both ESR1 and PIK3CA mutation positive. So this is 2.5 years. On AI adjuvant, bone-only, but heavy burden of disease, symptomatic patient with pancytopenia. At that time, we didn't have Inavo approved. If this would have been the case, what will be your first-line therapy? So I'm treating her
So that's a little
currently.
different question, right? When the patient has so much myelophysis that they're pancytopenic with their bone-only disease is really complete myelophysis after adjuvant therapy.
So let me just so I started treating her her pancytopenia has resolved. She has a good response to abema and fulvestrant. But if this would have been the case today, will you give her triplet therapy?
Triplet therapy with a PI3 kinase inhibitor at the same time?
Yeah.
Well, no, because she's going to respond beautifully, I predict, to abemaciclib plus fulvestrant. So
Because she did.
we don't need it.
No, but she responded. But what I'm saying, if you have to take a decision today, because this decision I took 9 months ago.
Yeah. So, I mean, we often encounter these kinds of patients where they have organ dysfunction, which means you can't give them a regular regimen, right? So in this case, you've snuck in the CDK4/6 inhibitor with the least amount of myelosuppression to clear out the bone marrow a little bit, and she's had a response to next-line endocrine therapy. Other parallels are patients who present with extensive liver disease, and you have to just use a little bit of chemo and hopefully get a response. I would, in the inavolisib trial, there is clearly more myelosuppression with the combination. So I think you made the right call, in all seriousness, by, getting her some benefit. And that's the challenge of, a clinical case that's always different from what a clinical protocol would look like.
Thank you.
I'm going to go to a case online. There seems to be a lot of interest in this. Danny and Mark Bowie, Dr. Mark Bowie, submitted 3 cases of patients with breast cancer that by liquid biopsy has identified JAK2 V16F mutations for progressing metastatic breast cancer patients, and wanted to know if this in any way influences treatment recommendations. JAK2.
Is it really coming from the breast cancer?
From the breast cancer, it's a good
The
question.
question
I
could
don't
be
know.
raised.
They could also just
often
have
in
a
that,
true and unrelated.
Yeah.
Yes,
Yeah.
they could have fleas and ticks. Yeah. Yeah. Yeah, so I think that's a question. I would say on a liquid biopsy, I don't know how you would distinguish that. And so
Probably to go back to the
probably go
primary
back to the
tumor.
primary tumor and biopsy it to look for somatic mutations.
Definitely.
Because I would suspect, like you do, that it could be coming from the hematopoietic cells. But good question. Okay, good.
I'm Googling this. Carlos Arteaga has a case report of somebody with a JAK2 amplified triple-negative breast cancer
Okay.
who responded to something. I'm scrolling as fast as I can here. I think the key point,
Because if
though,
they
is
didn't, it wouldn't have been a case.
I think the key point is you want to make sure she doesn't have a myeloproliferative disorder, right?
Yeah.
I mean, so she needs a bone marrow biopsy. I
For
would-
sure.
Yeah.
Yeah. Okay, let's go to the mic on the left. There, you're my left.
Yeah, okay. Hey, I have a case I'd like to ask you folks about. This is a 62-year-old woman who was diagnosed with a fairly large 2.2 centimeter palpable mass in her left breast, and she had a positive axillary node on ultrasound and also by biopsy. And she was ER 50%, PR 50%, and she was grade 2 to 3. We did a mammoprint on her, and she was a high 2 with like negative 6.3 or something. And she was started on chemotherapy with weekly Taxol and Carbo. She's about 9 weeks on that. She's had to miss 1 or 2 doses of Carbo because of myelosuppression. She's had a nice response. The tumor became unpalpable. It shrunk in size to a little less than a centimeter cubed, and the lymph node also got smaller to about 0.4 centimeters in diameter. And my question is, this is a high 2, but it's an ER positive. I know there's data that the ER positives back in the day didn't really matter what kind of chemo you gave them. You just gave them chemo and all was a wash. But does her high 2 make me more sensitive either to be cavalier and say she's going to be okay, or does she really need to be hammered with like AC afterward to make sure we give her everything and optimize her chemo? Again, she's ER 50%.
There's very little data here. Joyce O'Shaughnessy has reported on an experience where they characterized tumors as high 1 or high 2. These were all ER positive tumors. And in the high 2 designation, for those of you, originally, of course, mammoprint was high or low, and then they've sort of further subdivided it into very, really low, low, high 1, high 2. In the high 2 experience, patients who got an anthracycline-based chemotherapy were one of the few groups that actually seemed to benefit from anthracycline-based treatment. So I would have given this patient ACT. If she's struggling through the carboplatin, you have to assess if she can tolerate the anthracycline alkylator regimen or not. We had an interesting presentation this morning that patients who have fabulous responses in the first 3 cycles of chemo may not need all that much more, but it sounds like she's really not quite at complete resolution of disease. So I think she probably needs, anthracycline chemotherapy.
Okay, good, thank you.
And I think these high 2 tumors also were shown to have more Patt CR rates, so I think that's also an encouragement to treat these patients adequately with chemotherapy, whatever regimen you choose. I would agree with ACT.
Are you getting a lot of these newer mammo prints with the stratification?
Absolutely.
Right.
Absolutely.
And you found it helpful?
And I do, yeah, I do.
Let's go to this microphone over here.
Yes, good afternoon. Carlos Robles, Cape Girardeau, Missouri. I have a patient who was treated outside of the country at the beginning of January, 51 years old, 3 centimeters, luminal B, ER positive 70%, PR negative, HER2 low 1, Ki67 70%. She underwent a mastectomy, negative genetics. The tumor was 3 centimeters with 13 positive out of 16 lymph nodes. And so she was given the weekly paclitaxel double dense AC, and then she was supposed to start Verzenio and an letrozole, but before starting, a PET scan was done and compared to baseline. I'm not sure why this PET scan was done, but there is a new liver lesion and biopsy-proven metastasis, same kind. So primary refractory breast cancer, and the question is, she's young, she's 51. Would you just continue with abemaciclib-based therapy in addition to doing whatever genomic studies, or would you consider seeing that, being that is the only area of disease known, I don't know if it's a fantasy of cure, and try an ablation first and then do the adjuvant treatment?
Did you biopsy the liver and look
Yes.
at and it's ER/PR positive,
Yes.
HER2 new, negative,
Yes.
low also?
And are you sure that it's new? Did she have a PET scan before surgery?
Yes, there was a baseline PET scan
Okay.
that had absolutely nothing on the liver, just like 7 months ago.
Yeah, I mean, I think that AI and CDK4/6 is very appropriate for this patient. I think the question that you're getting at is, when do you locally treat with oligometastatic disease? I typically start patients on treatment and make sure that they prove that they're going to do well on that treatment. If the next scan she has 3 more liver lesions, then obviously you weren't going to benefit her by treating that. The duration is up for a little bit of debate. With CDK in the first-line setting, I would probably be thinking about maybe 12 months. And if she was doing very well, had a great response, did not have other disease, then I would potentially think about going back and treating that 1 lesion.
With ablation or surgery?
Typically, we use ablation.
Okay. Thank you so much.
Yeah, if may add from the radiation oncology perspective, of course, metastatic directed therapy is something that you should consider in this specific case. Guidelines did not recommend to treat without changing systemic therapy. You can do it only if there is an oligoprogression or oligometastatic disease in intracranial, but that we also kindly recommend to open or recruit in trials that randomize patients receiving metastatic directed therapy. That might be radiation or surgery, of course, ablative therapy, to understand if there is a benefit. And I perfectly agree with Erika's comment. You should always observe at least 3-6 months before deciding to add an MDT, because basically if you can have a high progressive disease, and in that case, metastasis-directed therapy is obviously not of benefit. Thanks.
I'm going to take one from the computer here. This is from Caroline Mishi, a 58-year-old woman with a truly heterogeneous breast cancer, an invasive lobular carcinoma, grade 2 ER/PR positive, HER2 negative in the breast, but with 3 out of 3 lymph nodes positive, and in the nodes, invasive ductal carcinoma that's HER2 amplified. And so I'm guessing the patient didn't have neoadjuvant treatment, and the question is regarding adjuvant therapy choice.
First, I would just say to make sure that she's had a breast MRI, to make sure there's not an occult primary that matches the metastatic disease. It's happened to all of us at least once, so I would do that first. And if she has 3 out of 3 positive nodes, she, according to current criteria, would qualify for a lymph node dissection to see what additional disease might be there that may inform subsequent therapies.
It's a great call out.
And it could be also of interest, but I don't know if for the patient it would be useful, but to compare the genomic profiles of the disease within the lymph nodes with the primary tumor, just to make sure they share or not genomic alterations in common. Probably not, knowing that one is lobular and the other one ductal, but just to make sure.
It's a great call out.
And then concerning radiation therapy thereafter, depending on the number of nodes, of course, if you go for laxative lymph node dissection, I kindly require to come tomorrow morning. There will be the Supremo trial that will send some data more on what to do in the case of 1 to 3 lymph node after post-mastectomy radiotherapy. That's very nice here in this Congress.
Wonderful. And so she's at least 3 out of 3 positive, but possibly additional surgery would inform additional. And then in terms of systemic adjuvant therapy, any of our medical oncologists want to weigh in?
I mean, for node positive, HER2 positive disease, we would usually give TCHP to an otherwise healthy 58-year-old, and then in this particular case, follow on with endocrine therapy. And so she has good options there in that sense.
Great. Wonderful. Okay, over here on this side.
I'd like to present a case from the Southern Hemisphere. So this is based around a question of stopping or treatment hiatus in the setting of prolonged complete metabolic response, but in recurrent triple-negative breast cancer. So the background of the case in 2018, early in that year, she had bilateral breast cancers. On the left was a triple-negative with HER2 0 expressing, and on the right was an estrogen receptor positive but HER2 negative breast cancer. She underwent neoadjuvant AC paclitaxel and had a complete metabolic response in the left, triple negative, but residual disease, not surprising, in the grade 2 estrogen receptor positive. She was commenced on adjuvant endocrine therapy, and at 4.5 years post her original diagnosis, patient underwent bilateral mastectomies at her choice, and no radiation was given in the adjuvant setting. At 4.5 years, she relapsed with internal mammary disease on the left-hand side, was biopsied, was estrogen, progesterone, and HER2 negative. HER2 was 0, but androgen receptors were strongly positive at 60%.
Did you say androgen receptors? Yeah.
Correct. I don't know why they were done, but they were just done. She had no other disease evident on PET scan, and she had carboplatin and gemcitabine and self-funded pembrolizumab because her PD-L1 expression was positive. Pembrolizumab at that time was not available in Australia for standard use, and there was no appropriate clinical trial. She had a partial metabolic response, and the patient requested surgical resection of the internal mammary group of nodes, and there was, not surprisingly, residual disease. So she had so-called adjuvant capecitabine and continued pembrolizumab to 12 months.
And still no radiation?
And received radiation to the internal mammary chain and to the supraclavicular fossa. She then completed her pembrolizumab at 12 months and had completed the capecitabine, and 3 months after completing her pembrolizumab, she represented with lower cervical chain lymph nodes and again a lymph node in the internal mammary. So she was commenced on sacituzumab govitecan, and 3 months after commencing treatment had a metabolic complete response on PET, and she's been maintained at complete metabolic response now for 15 months. And the question is, can she stop, or can she have a treatment hiatus, or does she just keep going?
I would favor keep going.
Yeah.
Of course, this is a data-free zone, but I would not feel comfortable stopping SASI at this point. Yeah.
I would agree with that.
if I add a comment, it's really important in this case also consider ablative dose. So in this case, probably rather than to treat both level of internal mammary nodes and 3-4 levels, we probably would go for just the positive nodes in the internal mammary node with a radiobiological higher dose. In this case, probably you have more control in that nodes, and you have the chance to treat again if you have relapse in other nodes, just in case of not response to the optimal systemic therapy, of course. Thanks.
And just a comment about the AR staining. Maybe the pathologist wanted to be sure it come from the breast. It's an indirect
Yeah, so
information, but it
GATA3
helps.
was also done, and that was positive. And she's had molecular sequencing. There was no mutations identified within the tumour for androgen. So again, it was discussed, should we be considering an anti-androgen? But I think she's pretty good on SASI.
Are her counts holding up okay?
They're
sacituzumab?
okay. So she's definitely starting to become neutropenic, and I'm starting to use a little bit of filgrastim. She found pegfilgrastim far too painful. And she's had ongoing low-grade diarrhea, even with a dose reduction. So she's at 75% dose.
I mean, the one other thing you could consider is a little bit of an alternate dosing schedule. If she's getting into trouble with side effects and counts, maybe, every other week. I've been successful with some patients with that.
So sorry, can you elaborate on
So
that?
instead of day 1, day 8, it's day 1, day 15, Q
Okay.
28 days.
Yep.
You just get into less count issues.
Thanks.
And she's had germline genetic testing with bilateral disease?
Yes, she has.
A question that's come up a few times here on the chat is anyone aware of any effects of pembrolizumab in fertility in the young triple-negative breast cancer patients? Any awareness of any complications specifically related to pembrolizumab?
I think it's a great question. I mean, the worry would be the immune endocrinopathies, essentially. And I have been counseling younger women who are starting pembrolizumab, but that is a possibility above and beyond the traditional side effects of chemotherapy and ovarian suppression. Certainly a lot of patients are ending up with fixable endocrinopathies, hypothyroidism, and to some degree adrenal insufficiency. There are case reports of more pan-hypophysitis, pan-pituitary kind of lesions, in which case they might become permanently infertile. So I think it is something you should be advising patients is probably rare, but is a possibility.
Great. Go ahead.
I'm Dr. Singhal from India. ADCs are not available everywhere, and as we understand in prostate cancer, chemohormonal approach is not for breast cancer. Is there a putative real-world scenario where one would consider a chemohormonal approach in an MBC setting, which is ER positive, HER2 negative, which is progressing on, say, AI and CDK4/6 inhibitor with a declining ER positivity on a new biopsy? Would you ever consider a chemohormonal approach?
I'm sorry, is the question, you have a patient with metastatic breast cancer that's ER positive, HER2 negative, you don't have antibody drug conjugates available to you, and is a next line of therapy a combination of chemo and endocrine therapy? Is that your question?
Chemo and endocrine therapy, especially in a patient who has rebiopsied and has a severely declining ER positivity status, say from 80% to 20% now.
Any comments?
And if not chemohormonal, why not? Why not chemohormonal approach as we do in prostate cancer? Why not in breast cancer?
So how are you going to?
I'll take it. I mean, so, for most patients with advanced breast cancer, they're going to get multiple lines of therapy. And in studies that were done in the 70s and 80s, they tried some of these things with very old flavors of chemotherapy and hormonal therapy. But in the long run, chemo-hormonal combinations did not improve on sequential single-agent approaches with endocrine agents or chemotherapy. Even in prostate cancer, they rarely give both at the same time, right? I mean, usually if you're going to get docetaxel as part of your induction phase for higher risk recurrence prostate cancer, you do that and then you switch over to androgen-targeted therapy. So I don't know that that's the paradigm this patient needs. If she needs chemotherapy, she needs chemotherapy, and then perhaps get a good response and reintroduce some hormonal treatment down the road.
Yeah, and I would say specifically with endocrine therapy and chemotherapy together, sequential single-agent treatment is probably overall more beneficial. And I think it begs the question when we see early data of some of these combinations that can be very expensive, is that going to, in the long run, be superior over sequential singlet or doublet choices in combination? And then, I mean, this is theoretical, not the data, but, the point of endocrine blockade really is to put cells in a cell cycle arrest, whereas, chemotherapy is kind of actively killing the cells that are rapidly dividing. And so you're sort of mixing strategies a little bit theoretically. So I wouldn't do that. Go ahead to our next person at the microphone.
Hi, Tiffany Trosa from New York. I have a case of a patient who's had several opinions and she wants a tiebreaker, so I thought, great to present here. So she's 46 years old. She was developed a right-sided breast mass at 8 months pregnant. Her lumpectomy and sentinel lymph nodes were removed at 35 weeks gravid. Her pathology showed a 2.2 centimeter, 1 out of 3 positive lymph nodes, invasive ductal carcinoma with extranodal extension. ER 85%, PR 80, HER2 1 to 2, FISH normal. So now she's 4 weeks postpartum, and her oncologist started her on Zoladex and tamoxifen. They sent off an oncotype, which came back at 21. So she's had multiple opinions, including one doctor recommending TC, and another doctor telling her that she doesn't necessarily need chemotherapy since she is postpartum and her estrogen levels have now been dramatically changed. And so they recommended Zoladex, AI, and a CDK4/6 inhibitor. She'll do what we recommend, but she is interested in additional opinions.
I can see why you got controversial opinions.
Yeah, and I think this is, an age-old question, and of course the offset study will help us answer this question, but I think it's good to be a discussion with that patient, that I don't think either of these approaches are wrong, but I think where we are, I do tend to favor chemotherapy for these patients until we have more data, but I think offset will definitely, I hope, help to answer this question.
I agree. I agree because of the node as well. I would offer her chemotherapy.
Yeah, I agree. I would offer her chemotherapy also, despite the low oncotype. I think oncotype and mammoprint are such useful tools when you're trying to decide whether or not to give chemotherapy. But I feel like this patient would have, sort of declared herself beforehand, that I don't know that I would have sent that in that particular patient. And then I would offer her 10 years of endocrine blockade and adjuvant CDK4/6 inhibition, stopping for subsequent pregnancy, should she desire to be reinitiated after 2 years.
So just a quick follow-up to that, she also has a pathogenic CHEK2 mutation. So would that alter your choices of chemotherapy or giving chemo at all?
Should probably be more sensitive to chemo.
No.
It wouldn't alter mine.
No.
Okay, thank you.
Okay, a question from the computer here. Does anyone feel differently? Would anyone here treat that patient differently? Just curious.
Just a comment on the importance of counseling here, because
Yeah.
you can really receive several distinct opinions here, and it's important for the patient to receive a high burden counseling to also to explain the indication to chemotherapy and the burdens. And here I think that a patient perspective here is really important in this case.
That's great. And I see we have a limited amount of time left. Can our patient comment at all about what happens when you have divergence of medical opinions? I know that's a very difficult road to navigate for patients.
It certainly can. You hope that getting second opinions and third opinions and fourth opinions provide clarity. But as we all know, you get 10 oncologists or any physicians in a room, you're going to get 12 different opinions. And I think what's really important is what you just said, that you have to really give the patient the information, give the patient the data. And I think in all circumstances, that if there is a clinical trial available, the clinical trial should be offered to the patient, especially in the metastatic setting, which is not to do with this case, but every single solitary patient with metastatic disease should be offered clinical trials. And there should never be the assumption that this patient is too old or too poor or lives too rural, et cetera, because we're not going to get the answers to these questions without people enrolling in clinical trials.
And I would just say, I think that in cases like this where it's controversial, I frequently will talk to patients about that uncertainty and what the area of uncertainty, why it is that you see divergence in doctors' opinions, because usually we're all trying to do the right thing for our patients. We have really reasonable reasons for the things that we do, and I sort of try to walk them down the different paths of what the risk is of various paths to try to help them navigate that complexity. I'm afraid we are out of time, and so that's all the questions we can take now, but thank you all for joining us, and thank you to my presenters.